we are going to have a very important speaker today with us, Dr. Kim Yong-jin, whom actually I have experience joining his course training and find it very useful. And for those who have not heard from him before, just a brief introduction. Dr. Kim completed his Doctor of Dental Surgery in the College of Dentistry, Tan Kok University. He trained in the Department of Oral and Maxillofacial Surgery at the College of Medicine, University of Ulsan, and he's currently the director of the Ilsan Apsang Dental Clinic, South Korea, and is a global course director for Osstem AIC Education Wing in Implantology. So without further ado, may we welcome him to share his knowledge on this very recent, to me it's recent, implant that we are getting in Malaysia to use. Over to you, Dr. Kim.
Thank you. Thank you, Professor Now, for your nice introduction. So I'm very happy to have this opportunity to share my experience about Osstem recently released new implant system. So I will start my presentation. Wait. So now I start my presentation. The topic of today's presentation is clinical application of chemically modified SLA surface implant. So I'm an oral and maxillofacial surgeon. I have graduated my dental college in 2004. Now I'm running a dental clinic with other specialists, including prosthodontist and endodontist. So first, I heard that in Malaysia, many dentists are using Osstem TS3 implant system, right? Yeah, this is a TS3 implant design overview. As you know, TS3 implant is taper body implant with 1.5 degree temp taper. So because of this taper design, we can get proper initial stability. So I'll skip the design of this TS3 implant. So today, I will be talking about clinical significance of implant surface. As you know, implant surface characteristics are factors affecting the rate and extent of the implant bone response. So by increasing the surface area, we can accelerate the speed of osseo integration because the osteoblast bone forming cell like rough surface. As a result, we can get better bone to implant contact ratio. As a result, we can decrease overall treatment period. This is the main goal of implant surface treatment. There are various kinds of implant surface: blasting surface, RBM, SLA, hydroxyapatite coating, and anodizing. But in these days, many manufacturers are producing implant with SLA surface. The SLA surface was first introduced by Straumann Implant Company in 2003. This is a same image of SLA surface, quite rough surface. So, do you know how to make this SLA surface? After making thread, with thread sandblasting with aluminum oxide particle will be done to make a rough surface. So crater, macro-ripples will be formed with this sandblasting process. And then, in order to maximize the surface area, exit etching will be done. With this exit etching process, micropit will be formed. So you can see this kind of micropit here. So, but the main disadvantage of this SLA surface implant is this one, hydrophobicity. The surface energy of this SLA surface will be decreased. So affinity to the saline and affinity to the blood will be decreased. So we can call this phenomenon as a hydrophobicity. So to solve this hydrophobicity of SLA surface implant, Osstem recently released a new implant surface called ETIII-NH with hydrophilic surface. So I want to briefly introduce this ETIII-NH implant. So basically, this ETIII-NH implant has SLA surface base. The basal surface of this ETIII-NH is a SLA surface. But after making SLA surface implant, unique bioresorbable apatite nano coating was done. Let's see. As shown in this slide, you can see this black area. Black area means SLA surface, and the gray color means hydroxyapatite coating. Unlike HA coating implant, this ETIII-NH implant has base And also to evaluate the quality of osseointegration, bone implant contact ratio, and removal torque are frequently used. BIC, bone implant contact ratio, is the ratio between entire implant surface to implant surface with bone contact. The higher BIC means the higher quality osseointegration. The other method is the removal torque. After placing implant, wait some time and then remove. By measuring the removal torque at the time of implant removal, we can expect the quality of osseointegration. The strength of osseointegration can be measured with this method. Here, there was a high removal torque of NH implant. This means the strength of osseointegration was higher in NH implant, hydrophilic surface implant. So the quality of osseointegration will be high in hydrophilic surface implant. So we can get strong osseointegration with thick and dense bone around hydrophilic surface implant. So to summarize, by stabilizing the blood clot around the implant surface, we can maximize osteoblast adhesion over the implant surface. As a result, fast and strong and dense osseointegration will be possible. So the entire quality of osseointegration will be increased. That's the main reason why we should consider hydrophilic surface to overcome poor bone quality and quantity. Yeah. So this hydrophilic surface implant should be considered to overcome the poor bone quality and quantity. So from now on, let's talk about clinical applications of this hydrophilic surface implant. I think the first indication of this hydrophilic surface implant is the soft bone. So as you know, according to the location, the bone density is different. In the posterior maxilla, the bone quality is quite soft, D3 or D4 bone. So this is, as shown in this slide, the influence of bone density on implant success rate. After placing implant in the soft bone, the implant survival rate will be reduced. Why? The sparse trabecula of the bone often found in the posterior maxilla offer fewer area of contact with the body of the implant. After placing implant in the soft bone, the bone implant contact ratio will be lower than that of normal bone or hard bone. As I said, the BIC is a parameter of the quality. The BIC is a parameter of osseointegration. The higher BIC means the higher osseointegration. In the deeper bone, the cancellous bone density is quite low, so we cannot increase the BIC, bone implant contact ratio. So the success rate of this implant will be decreased. That's the main reason. Yeah, this is the research about longevity of dental implant in type 4 bone, soft bone. In type 4 bone, the overall survival rate is less than 90%. But interestingly, the survival rate of treated surface implant inserted in the low density bone was higher than that of machine surface implant. by using surface-treated implant, we can increase the success rate or survival rate of implant even in the soft bone. So based on this research, I think the hydrophilic surface implant should be considered in the soft bone. So sometimes we may experience these kinds of soft bone. The comparison between comparison of wide diameter implant and hydrophilic surface implant in poor bone quality cases. Let's see this case. I placed 2 implants in the left maxilla right after extraction. Here, because of prolonged edentulous tape tooth of opposite arch, there was a severe extrusion of left upper molars. Here. This is the pre-op condition, closal view and lateral view. Yeah, because of severe extrusion of left upper 2 molars, there was no vertical space for crown. So I decided to grind the bone vertically to secure appropriate vertical dimension for prosthesis. So first extraction was done, and then vertical reduction osteotomy was done. I cut the bone with the bone longer, like this. After grinding the bone, I could secure the vertical dimension for prosthesis, but unfortunately, crestal cortical bone was gone completely. So 2 implants should be placed inside, should be placed in the cancellous bone. So to perform crestal process lifting, osteotome was utilized. I fractured the sinus floor, and then 2 implants were placed. In the postmolar area, I placed hydrophilic ETIII NH implant. The diameter was 5.0, the length was 11. Second molar area, I placed hydrophobic surface TS4 SA. The diameter was 7.0, the length was 10. Yeah. Even though I placed 7.0 diameter implant in the second molar area, the initial stability was less than 1.5 Newton centimeter. So I submerged these 2 implants. Bone grafting and gap filling was done with autogenous bone. Yeah. Because the initial stability was quite poor, the ISQ value could not be evaluated. So submerging was done. Yeah. And opposite side, I placed 2 implants like this. Also, the vertical reduction osteotomy was done on the mandible to secure the sufficient vertical dimension for prosthesis. Yeah, this is a comparison before and after. Here, this is a post-operative panorama. MPA and CBCT. The sinus floor was fractured successfully without any sinus membrane perforation. So crestal approach sinus lifting was done successfully. And 3 months later, soft tissue got healed very well. So second stage surgery was done. Flapness method. I didn't open the flap. I just grinded the gingiva with diamond bar and then removed the cover screw and healing abutment were connected. Yeah. 3 months after implant placement, second stage surgery was done. Right after connecting the healing abutment, I measured the ISQ value. Here, around the ISQ value of post-molar implant was 68 and 70, higher than second molar implant. The second molar implant was ultra-wide diameter implant, 7.0. 4 months, 16 weeks after implant placement, ISQ value evaluation was done again. Let's see, more than 70 in second post-molar implant. How about second molar implant? Less than 70. So after checking, after experience this, I usually place hydrophilic surface implant in the soft bone. So 4 months, 16 weeks after implant placement, impression taking was done. And then final prosthesis was delivery was done 18 weeks after implant placement. This is a panorama after final prosthesis delivery and PA. So I strongly believe that this hydrophilic surface implant should be considered for the first time when placing in the soft bone. As I said before, by stabilizing the blood clot around implant easily, we can increase the bone implant contact ratio, even in the soft bone. Yeah, this is another evidence of hydrophilic surface in the soft bone. It was suggested that the threshold should be determined according to the implant surface state and the implant design. As you all know, micromotion is the main enemy of osseointegration. For implant with a bioinert surface, the critical threshold lies somewhere between 50 and 150 micrometer. Possibly 100 micrometer may be the threshold level as proposed by Bronsky as a rule of thumb. Nevertheless, it was suggested that this threshold should be determined according to the implant surface state and implant design. In other words, implant design and the implant surface status are the determining factor. So, and in addition, the calcium phosphate coated implant tolerate more micromotion than the equivalent non-calcium phosphate coated implant. Surface treatment with hydroxyapatite coating method is quite good solution in the soft bone. So HA coated implant was mainly placed in the soft bone. But what's the main disadvantage of hydroxyapatite coating implant? Delamination. The hydroxyapatite coating layer will be delaminated, separated from the main surface easily. So once this hydroxyapatite layer is dislodged from the implant surface, this hydroxyapatite layer will be an infection source. So high failure rate was observed after placing hydroxyapatite coating implant. Instead of that, this ETIII NH will be quite good. Will be a good alternative of hydroxyapatite coating implant. In 2003, Dr. Davis once said like this: in the soft bone, optimizing contact osteogenesis by implant surface design to ensure early stability is of great importance. As you all know, there are two kinds of bone healing after implant placement. The first one is a distance osteogenesis. In the distance osteogenesis, the bone formation will occur from the residual bone. From the periphery of drilling site, the bone cell will migrate to the implant surface. So the direction of new bone formation is from residual bone to the implant surface. This is a distance osteogenesis. The another method is a contact osteogenesis. If osteoblast can adhere to the implant surface directly, there will be a bone formation on the implant surface. And also, additionally, there must be new bone formation from the native bone to the implant surface. So, multi-directional new bone formation will be possible. As I said from the beginning, osteoblast likes rough surface. So after placing rough surface implant, we can expect direct adhesion of osteoblast on the implant surface. The distance osteogenesis has been explicitly described to explain the phenomenon of osseointegration of machined metallic implant. Osteoblast doesn't like rough surface. Osteoblast doesn't like machined surface, smooth surface. Only after placing rough surface implant, we can expect osteoblast adhesion. But how can we maximize the osteoblast adhesion to the implant surface? By placing hydrophilic surface. ETIII NH has a SLA surface. The basal surface is SLA. Additionally, hydrophilic surface. ETIII has hydrophilicity, so blood absorption and blood class stabilization will be much better than SA surface implant. So we can maximize contact osteogenesis. So when placing implant in the soft bone, this hydrophilic surface implant should be considered. And second indication is immediate implant placement case. When after placing implant immediately, right after extraction, we should consider this gap. When managing this gap, we usually refer to this article, this research about jumping distance introduced by Dr. Botticelli in 2003. Jumping distance is a maximum gap distance which can be filled with native bone without any bone grafting procedure. Until now, this jumping distance is known as 2.0 mm. So when the gap is less than 2 mm, spontaneous bone healing will occur without any bone grafting procedure. But when the gap size is greater than 2.0 mm, at that time, we should pack the bone to fill the gap to get complete bone regeneration around exposed implant. So after placing SLA surface implant, when the gap is greater than 2.0 mm, I usually fill the gap with the bone graft material. And then primary closure was done. This was my routine with SLA surface implant. But I think like this. If we can maximize contact osteogenesis by stabilizing the blood clot around exposed implant. Like this. As we all know, this blood clot can be a scaffold for newborn formation. If we can stabilize this blood clot directly around exposed implant, can we skip the bone grafting procedure regardless of gap size? This is my hypothesis. Could hydrophilic surface implant increase the predictability of no bone graft after immediate implant placement, regardless of gap size? So I performed human biopsy to find out clinical evidence. So let's see, this case, immediate implant placement was done in the maxilla, except left first and second premolars. Remaining teeth were extracted, and then immediate implant placement was done. This is a pre-op condition. Here, on the right side, I placed 4 implants, canine, first premolar, first molar, and second molar. And second premolar area, I performed histological evaluation. Here, I placed 3.5 diameter TS3 implant with hydrophilic surface. Here, the length was 8.5. As shown in this photo, the gap size was greater than 2.0 mm, but I didn't perform bone grafting. No bone grafting, even though the gap size was greater than 2. And then I removed this implant with trapine bar for histologic evaluation after 12 weeks. This is a post-operative panorama. Here, histologic evaluation was done 12 weeks after implant placement. 1 week later, the soft tissue got healed very well. 12 weeks later, soft tissue healing was quite promising. But I wanted to check the amount of new bone formation along the exposed implant surface without bone graft material. So I made the indentation medial side of healing because there was no bone contact in the medial side of this implant. And then to cut the implant in medial-distal direction, I made the indentation on the medial side to compare the medial side and the distal side. Here, I open the flap. And then by using the trapine bar, I remove this implant along with the adjacent bone, like this. Here, let's compare before and after. 12 weeks after, there was successful bone regeneration inside the gap without any bone graft material. But I really wanted to check the new bone formation along the implant surface, especially in the medial side. So in this specimen, there was a successful bone regeneration along the implant thread. So I made the slide for histology evaluation. So I cut the implant in this direction, medial-distal direction. And H&E staining was done. I measured bone implant contact ratio. And then I compared the medial side and the distal side here. This is a result of a histologic evaluation. The medial side without bone contact, the BIC was 52%. How about distal side with bone contact? In the distal side, the implant was placed inside the bone, native bone, On medial side, there was no bone support. The distal side, the BIC, bone implant content ratio, was around 58%. Not too bad. So I think based on this histologic evaluation, I might conclude like this. After placing hydrophilic surface implant immediately, we can skip the bone grafting procedure only if you can see the blood clot stabilization like this. In here, I place one implant in the second molar area, upper second molar area. The buccal bone and palatal bone was so intact without any bone defect. So this is a self-contained defect. So 5 months after installation, you can see sufficient blood clot stabilization. This blood clot can be a scaffold for new bone. So I just connect the wide diameter healing abutment, and then 2 weeks later, there was successful soft tissue regeneration over the blood clot. And then 12 weeks later, final prosthesis was fabricated and delivered, and then CBCT taking was done. Let's compare. Immediate post-op CBCT. Even though there was a gap greater than 2 mm, there was a successful bone regeneration inside this gap. And also, buccopalatal width could be maintained well without any collapse. Yeah. So third indication is implant placement with crestal approach sinus lifting. This is my protocol of crestal sinus surgery. When the residual bone height is greater than 4.0 mm, I usually perform crestal approach sinus lifting. When the residual bone height is less than 4.0 mm, I usually perform lateral window approach. But I think current trend of crestal approach sinus lifting is no bone grafting. Should we always place bone graft material inside the sinus for new bone formation? I don't think so. Many dentists strongly believe that bone graft material itself can be changed to patient own bone. That's not true. To make a bone forming cell, osteoblast should be supplied. Inside our human body, only osteoblast can make a bone. So if we can make an environment for sufficient osteoblast supply and holding, we can skip the bone grafting procedure. And this is a quite recent research about maxillary sinus floor elevation with simultaneous implant placement without bone grafting procedure. So quite interesting. How much bone can we regenerate without bone graft after crestal approach sinus lifting? In this research, in this systematic review, on average bone gaining in bone height inside the sinus was 4.7 millimeter. And cumulative average survival rate was around 97%. So quite good. Without any bone graft material, we can increase the bone height inside the sinus around 4.7 millimeter without any bone graft material. But we should consider one more thing when considering this no bone grafting crestal approach sinus lifting. Many dentists usually check the residual bone height But it is not just about the residual bone height. We should consider one more thing: sinus width at the proposed implant apex. When the buccopalatal width of proposed, when the buccopalatal width of sinus floor is greater than 12 millimeter, that sinus can be classified as a wide sinus. Less than 12, narrow sinus, like this. So increasing sinus width will not only increase the risk of sinus membrane perforation, but also make it less likely that you get intrasinus bone coverage. According to the sinus width, the success rate and the predictability of no bone grafting crestal approach can be different. Internal manipulation of sinus membrane should be perfectly the same as lateral approach in the respect of graft material ossification. We need broad detachment of sinus membrane. When the buccopalatal width of sinus floor is quite narrow, we can detach the sinus membrane sufficiently. We can expose wide surface of bone inside the sinus. But when the buccopalatal width of sinus floor is quite wide, it will be quite challenging to detach and elevate the sinus membrane sufficiently. So it will be difficult to expose bony surface inside the sinus cavity. So bone forming cell supply and blood supply will be limited. So in this situation, if we can place hydrophilic surface implant, I think this hydrophilic surface enhance the predictability of sinus lifting without bone graft, especially in case of broad sinus floor. So let's see. In this case, I place 2 implants in the right maxilla right after extraction, 1.6 and 1.7. This is a free of CBCT. 1.6 implant was presenting palatal bone defect because of severe periodontitis. So I decided to perform crestal approach sinus lifting with osteotome, and then implant placement was done. And then to regenerate the palatal bone, I used the smart builder. Yeah. Right after extraction, I open the flap to check the palatal defect, and then I placed 2 implants. Here, 1.6. Post molar area, I placed hydrophilic surface implant after sinus floor fracturing. And then, as I said before, the smart builder was placed to palatal side to cover palatal bone graft material. And then connective tissue grafting was done over the smart builder to avoid smart builder exposure. And then primary closure around healing abutment was done. Here, this is a post-operative panorama and PA and CBCT. And 5 months later, smart builder was removed. And here you can see successful bone regeneration inside sinus cavity without any bone grafting material. Here, I just elevate the sinus floor along with the sinus membrane with osteotome, and then hydrophilic surface implant was placed. And palatal bone was regenerated very well. And let's compare before and after. Here, you can see the increased sinus floor and new bone formation inside sinus cavity. And also here, successful bone regeneration in the palatal bone defect. So in the previous case, I used this osteotome, but let's remind this requisite for successful crestal approach. To to perform successful crestal approach sinus lifting, we should not perforate the sinus membrane. And most important thing is this one, broad detachment of sinus membrane, same as lateral approach, should be done to expose bone surface widely, because bone forming cell comes from bone surface. So by elevating and detaching the sinus membrane broadly, we can expose the wide bone surface. So as a result, we can maximize osteogenic cell supply. So in the panorama, these two situations looks seems to be same, but success rate and predictability will be completely different. Which one will be better? When considering the bone forming cell supply, the right side will be better. The bone grafted area should be supplied by bone forming cells from minimal 3 bony walls. So we should detach the sinus membrane broadly. In that point of view, which one will be better? Osteotome and cascade. I think the cascade will be much better, because we can detach and elevate the sinus membrane broadly by using hydraulic lifting system. Wide sinus membrane detachment without membrane perforation will be possible by using hydraulic lifting system. So here, I place single implant in right maxilla. Pre-op condition here, buccal palatal width was quite good, but residual bone height to the sinus floor was quite limited, more than 4 mm. So crestal approach sinus lifting was done, but I didn't place graft material. This is a parallel guide kit. To make an initial drilling point at the center of restorative crown, I use parallel guide kit. This is quite simple and useful kit. And then cascade to perform crestal approach sinus lifting. And sinus floor fracture was done, and then hydraulic lifting was done to detach and elevate the sinus membrane well, broadly. And then this is the ETIII NH implant with hydrophilic surface. As shown in this video clip, I didn't place bone graft material. So, yeah, this is a panorama and PA. As shown in this panorama, there was no bone graft material inside the sinus cavity. Here, you can see the elevated sinus membrane. Underneath the elevated sinus membrane, there was blood clot stabilization around the implant surface. 3 months later, dynaprosthesis was fabricated and delivered, and this is a PA. Here, can you see the elevated new sinus floor here? So CBCT taking was done. Only 3 months had passed after implant placement, but there was new bone formation and underneath the elevated sinus membrane, and also new cortical bone formation over the newly formed bone. This will be a new sinus floor. 6 months later, and this is CBCT after 6 months. Yeah, let's compare before, and this is immediate post-op, and 6 months follow. Without any bone graft material, I could get successful new bone formation inside the sinus cavity by using the hydrophilic surface implant, like this. This is a comparison of panorama. So I want to share one more case. I placed 3 implants in the left maxilla. Okay. Even though the residual bone height was less than 4 mm, I performed crestal process lifting with a casket because the buccolingual width of sinus floor was quite narrow. So here I placed 3 implants. I opened the flap and lutherist extraction was done, and then drilling with a casket and hydrolifting was done. And then I placed 3 implants with hydrophilic surface. As shown in this panorama, there was no bone graft material placement inside the sinus cavity. Here. Only hydrolifting was done. In post-molar implant area, the residual bone height was less than 4, but I tried crestal process lifting. 18 weeks after implant placement, final prosthesis was delivered. And this is a panorama, this is the PA of the final prosthesis delivery. You can see some new reformed elevated sinus floor. So parallel CBCT taking was done 6 months after implant placement. This is 6 months. You can see successful bone regeneration inside the sinus cavity around post-molar implant. Let's compare. This is the immediate post-op CBCT. You can see elevated sinus floor, elevated sinus membrane. And underneath the elevated sinus membrane, there was a blood clot. 3 months later, you can see some increased and new bone formation. And 6 months later, more bone formation here. I think this is the power of hydrophilic surface. Yeah, we can get this kind of situation with SLA surface, but we can decrease the period of new bone formation by placing hydrophilic surface implant. 1 year follow, immediate post-op PA, and 1 year follow. And 2 years follow, pre-op and 2 years. Without any bone graft material, I could get successful bone regeneration. 2 years follow-up CBCT. So final indication is GBR. Why should we consider hydrophilic surface implant in the GBR cases? As you know, to get successful bone regeneration, we require 3 important factors: spacemaking, and blood clot, and bone forming cell. I think the blood clot is quite important. This blood clot is the matrix for invasion of blood vessels and granulation tissues and open bone. And more important thing is this one. We can get growth factors by platelet. Inside the platelet, there are PDGF, platelet-derived growth factor, and TGF-beta. These 2 growth factors are important growth factors for skeletal tissue regeneration. So by stabilizing the blood clot around exposed implant, we can increase the success rate of GBR. So this is my final hypothesis. Could hydrophilic surface enhance the predictability of GBR by stabilizing the blood clot? So this is quite interesting research. In this research, the comparison between hydrophobic SLA surface and hydrophilic SLA active surface was done. Bone regeneration in descent type defect at the chemically modified and conventional SLA titanium implant was done. Within the limit of this study, it could be concluded that modified SLA titanium surface may promote the bone regeneration in acute type buccal dehiscence defect as submerged implant. Here, after placing around hydrophobic SLA surface implant, there was no bone regeneration. But around hydrophilic SLA active Straumann implant, there was spontaneous bone regeneration without any bone grafting material and membrane. As I said before, by stabilizing the blood clot around the exposed implant surface, this hydrophilic surface can make a bone without any bone graft material. Yeah. So similar research was done with Osstem TS3 implant. One side hydrophobic implant, the other side hydrophilic implant was placed in the dehiscence defect model. So around hydrophobic implant, there was no bone regeneration. Around hydrophilic surface, there was some bone regeneration. Partial bone regeneration would be expected around hydrophilic surface. So as you all know, cumulative implant survival rate has been shown to be clearly lower than those regularly reported for implant placed into sufficiently dimensioned alveolar leads. GBR should be considered as a risk factor for the implant longevity. Augmenting bone at the exposed implant thread may involve additional risk factors for the longevity of dental implant. So when performing the GBR to cover the exposed implant, we should do our best to maximize the predictability of newly formed bone. So the preservation of blood clot, which can be converted in new bone, is essential for successful GBR. So the hydrophilic properties of implant surface may play an important role in the blood clot stabilization. So if we can stabilize the blood clot, we can increase the success rate of GBR. After placing particulated bone, this blood clot can play a role to stabilize this particulated bone. The stabilization of graft material is quite important factor to get successful bone regeneration inside bone graft material. So by placing hydrophilic surface implant, we can get the blood clot around the exposed implant. So through this blood clot, osteoblast migration will occur to the implant surface. So how can it maintain the space? By using the smart builder, which can be connected to the implant. This smart builder can play a role as a space maker. So I performed the clinical trial in the dehiscence defect with hydrophilic surface. Here, like this, hydrophilic surface implant and the smart builder without any bone graft material in the dehiscence defect. Let's see here. 1/4 extraction was done 3 months ago because of severe periodontitis. So to get successful soft tissue healing, 3 months with serious healing period, soft tissue got healed very well. So I opened the flap, and then this second premolar implant was removed because of fracture with trapine bar. But I placed one implant in here, the first premolar area, 1/4. This is a hydrophilic surface TS3 implant. Even though there was a decent defect, I didn't perform the bone grafting. 5 minutes after implant placement, there was a stabilization of blood clot. So, as I said, this blood clot can be a scaffold for newborn, but how can it maintain the space for newborn formation? The buccal flap will press down this blood clot, so ideal bone regeneration was impossible. So I used the smart builder to maintain the space underneath the buccal flap to regenerate bone with ideal contour. And then primary closure was done without any bone grafting material. So this is a panorama after implant placement. Okay. And 3 months later, I opened the flap to remove smart builder. Underneath the smart builder, there was a severe soft tissue formation because I didn't place the graft material. So to check the newborn formation, I removed this soft tissue layer completely. Underneath this thick soft tissue layer, there was successful bone regeneration. Let's compare before and after. This is my just clinical trial. I didn't perform this kinds of treatment anymore. This is just my clinical trial to check the clinical effectiveness, the hydrophilic surface implant in case of GBR. So this is my conclusion. By placing hydrophilic surface implant, we can get sufficient blood clot stabilization and bone cell supply. And by using smart builder and the bone graft material, space making can be sufficient. So this is the reason why we should consider hydrophilic surface implant in case of GBR. Stabilization of blood clot will stabilize the particulated graft material. So containment of graft material is possible. So I think the best combination for successful bone regeneration in descent type defect is hydrophilic surface combined with smart builder and bone graft material. We can maximize the success rate of GBR. I think so. So I want to conclude my presentation. So why should we consider hydrophilic surface? First indication is soft bone. By maximizing the contact osteogenesis, we can get predictable result in the soft bone. And also, we can reduce the early failure rate. So second indication is immediate implant placement. After placing hydrophilic surface, we can increase the jumping distance, so less possibility of bone grafting. Third indication is crestal process lifting without bone grafting. By stabilizing the blood clot underneath the elevated sinus membrane, we can increase the predictability of crestal process lifting without bone graft. So we can simplify the crestal process bone grafting procedure. The final indication is GBR case. By stabilizing the blood clot like this, we can increase the predictability of GBR. The stabilization of blood clot which can be converted to the new bone. So hydrophilic surface implant may play a very important role in bone regeneration. So I think this is an entire paradigm shift. Dr. Brennemark has placed his first implant in the human in 1965. After that, more than 50 years has passed. At the time of beginning, the survival of implant was the main issue. In 1980, Dr. Albrechtsen first introduced the success criteria of implant. After that, success of implant was the main issue. Many implant companies advertised with their success rate. Many implant manufacturers advertised their own implant with high success rate. But in this day, any implant company doesn't advertise their own implant with success rate. I think third paradigm of implant treatment is predictability. To overcome insufficient bone quality and quantity, we need something better implant system. I think the hydrophilic surface implant is quite good solution to overcome insufficient bone quality and quantity. In that point of view, ETIII NH implant will be quite good weapon to overcome the poor bone quality and quantity. By using this implant, we can increase the possibility of minimally invasive surgery by skipping the bone grafting. So thank you for your attention, and let's have a Q&A time.
Thank you, Dr. Kim. Interesting lecture. I learned a lot. And right, let me just have a peep at the chat if anybody have left any questions so far. Right, so while you thinking or typing, maybe I can start with first question. You show us cases with your sinus leaf, right? And you did not put bone graft in that, and we know that it does work. Well, the question that I have in my mind is, how much can you put it into the antrum before you make a decision and say, okay, 4 millimeter, I want to leave it alone. 5 or 6, you may want to put bone. Is there a number that we can predict? Use to predict?
Yeah. So according to the bone height, the treatment approach method can be different, but my minimum is 4 to perform crestal approach sinus lifting.
Yep.
Less than 4 millimeter lateral approach.
Right. How about the inside, the part of implant that goes into the
amount of
between the sinus lining and the implant?
I usually place the 10 millimeter length implant in the posterior maxilla. Yeah, around 6 to 7 millimeter intrusion will be okay.
And without bone?
Yeah.
Wow, that's a lot. I dare not do that.
Yeah, several researches stated that according to the amount of implant protrusion to the sinus cavity, the amount of newly formed bone can be different.
True. Do you have any particular type of bone that you prefer to put on the sinus if you need to put bone into it?
So I prefer allogenic bone inside the sinus to make patient own bone.
You not worry about resorption. Yeah, but we do have resorption, isn't it, with allogenic?
Yeah, because of the resorption rate, I usually perform overgrafting. 30% overgrafting. Yeah.
Sure. Okay, good. Right. I think our group here is quite quiet. If anybody want to raise your hand, please do. Yeah. So I know maybe you're not so happy because we didn't do well in the badminton just now. Uh, maybe another question from me then. You show us the case where you put smart builder,
Yeah.
right? You use smart builder to hold the cloth.
Yeah.
How about PRP? Do you have any experience PRF or PRP? I mean, you have a hydrophilic implant. You
Yeah.
have a nice blood clot that forms around it,
Yeah.
but I mean, our fear is that blood clot disintegrate or disappear.
Yeah.
Would a membrane or a PRP or have be doing the same job like what the smart builder is doing?
Yeah, right. So, but the main reason of smart builder is to maintain the space. That's the
Yeah.
main reason. So, as you mentioned, by using the PRF and PRP, we can get the same effect as a blood clot around the hydrophilic surface.
Right.
Yeah.
Okay. Right. Um. Okay. Right. So no, I end up being the person asking the question now all the time. All right. I'm going to stop for a while. Anybody want to raise their hand or type in the chat? There's a question. How long do
Yeah.
you wait before loading?
So I usually use ISQ value. I usually measure the ISQ value. So if the ISQ value is greater than 70, that's time to load. But less than 70, I usually wait 3 to 4 months after implant placement.
Right. So if it's a D4 bone, like what you have shown
Yeah.
us, the very soft bone,
Yeah.
you will have to wait longer. Am I correct to say that?
Right. Exactly.
Okay.
Yeah.
Yep. Good. Right. Anybody else has anything there? Did I miss anything on the chat? Gosh. We're
Not
doing
from
good with
my
the chat.
end. So far, there's only 2 questions that were asked. I think the second one has already been answered.
What's the first one? Did I miss it?
The first one asks, is there any performance difference between implants with CA surface and NH surface?
So once again,
Is there any difference between the CA and your NH?
NH
Yeah,
surface.
because the NH is quite new.
Yeah.
Right?
So
Before we
CA
jump to
implant,
NH, yeah.
Yeah, is contained in the calcium chloride solution. NH is a
Yep.
dry type. And
Yep.
so, but surface energy is higher in the NH implant.
Right.
And also, this nano size hydroxyapatite layer is quite good to get better early bone response.
Right.
Yeah.
Okay. Right. I have a question here, but I think we have answered it. What is the minimum sinus bone height to perform internal sinus lift without bone graft?
And so according to the sinus width, the minimum, it can be different, but 3 to 4 millimeter is my minimum.
Mm-hmm. Okay. Will the cost of the type of implant make different decision to be taken? Wow, somebody asking about cost. You see the chat on your screen as well, Dr. Kim?
Yeah, I cannot see the chat.
Right. Okay, let me read it out then. Will the cost of the type of implant make difference in decision? Meaning that would you want to use A, B, C from Osstem and then because A is so-called a little bit more pricey than the other, is there any decision based on cost or you decide because you think hydrophilic is better, NH is better, that kind of situation? So you look at the case.
What case? Cost?
Yeah, I mean whether the cost of the implant influence your decision making.
No. So in the hard bone and the normal bone, I usually place TS3 assay. But
Right.
so if the patient has some osteoporosis or the bone quality is quite poor at that time, I explain the importance of hydrophilic surface. And then hydrophilic surface implant, I recommend all hydrophilic surface implant to my patient, and then additional cost will be added.
Okay. The next question is, if the patient is much, how do we induce the clot? Sometimes the bone and the socket is a little bit dry. Do you do anything to make it bleed a bit more?
Yeah. So by using the round ball, I make some perforation on the corticals inside the extraction socket.
Right.
Yeah.
Okay. So you do induce the bleeding, yeah?
Yeah.
Right. The next question is, since the nano-hydroxyapatite layer or the coating is thin, is there a worry about the surface coating damage or peel off during implant insertion?
Surface damage. Yeah, but the particle size is quite small. Nano size hydroxyapatite particle was coated on the NH implant.
Yeah.
Even though the insertion torque is greater than 15 Newton centimeter,
Yeah. But
there was no delamination.
how about D1 bone? Is there a problem that you worry? Because hydroxyapatite has a problem 20 years ago when they do it, right? They delaminate.
Yeah.
Do this current have this problem?
Even though this nano size hydroxyapatite particle can be dislodged when placing implant in the D1 bone, but particle size is quite small, can be resolved easily.
Right.
Yeah, no need to worry about
be a
that.
problem.
Yeah.
Okay, right. Okay, the next question is immediate placement implant. Do we routinely use this new implant? So they're asking whether this new implant that we're talking about, the NH or ETIII, right? ETIII, whether
Yeah,
it is the preferred one for immediate implant placement.
So this is not absolute indication. Until before the NH, ET3 NH, we placed implant immediately with the TS3 assay, right? But this is not absolute indication. But as I said during my presentation, to increase the predictability, to simplify the procedure, NH implant will be better than assay. That's my opinion.
Right. Okay. No more question at the moment. Maybe I should ask another question before we call it the day if there's no more. Is there any contraindication of this use of the implant? I mean, people with allergy or things like that. Is there an issue? Because we know there are people who are even allergic to titanium, for example.
Yes, some patient, very rare patient, has allergy to the titanium. So to find out real allergic reaction, I usually use a titanium disc, just like a skin test. After fabricating the titanium disc on the patient back or abdomen area, I attach the titanium disc for 24 hours and then check the skin reaction. If there is some rash or itching sensation, that means this patient has a titanium allergy. At that time, the titanium implant is not indicated. That's my method.
But how about this new one?
No need to worry about this.
You don't think people who are allergic to the hydroxyapatite?
So hydroxyapatite is a major element of the bone and teeth.
Yep.
No allergy to the hydroxyapatite.
That's good news, isn't it?
Yeah.
Now I'm worried because this is we do something to it, we process it. You see,
Yeah.
sometimes we do not know whether in the process of doing that we added chemical or something like that to it.
Yeah, but
Right.
also, yeah, this hydroxyapatite particle is quite small, as I said. So resolvable, bioresolvable.
Right. Right.
All right. So with that, I think we'll come to the end of today's webinar. So thank you, doctors and esteemed guests, for attending the session. Don't forget to tag your pictures on Facebook because we have some exciting prizes to give away, and those winners will be announced within 2 or 3 days' time. So keep a lookout on Osstem Malaysia page for more information. And with that, we end today's webinar. So thank you for attending today's event. Thank you and good night, everybody.
Thank you. Good night
Yeah,
and
thank you,
stay safe.
everybody. Thank you, Dr.
Bye.
Kim.
Bye.
Bye-bye.
Thank you.
you.
Thank you
Great
now.
lecture. Thank you. All right.
Thank you. Bye.